Reason number 1 why that $5 saline bag hits your hospital bill at $800? It is a hidden markup game you will not believe. And it has been going on for decades, right under the noses of patients, policymakers, and the press. Stick around, because by the end of this video, you will have uncovered the top 5 culprits behind this hospital pricing scandal and walk away armed with 5 proven actionable strategies to slash your bill. This is not a rant. This is a full breakdown, backed by real data, real stories. Today, we are diving deep into one of the most infuriating corners of American healthcare economics, the shocking markup on IV saline bags. On the surface, it sounds almost absurd. We are talking about a bag of salt water. Literally, sodium chloride dissolved in sterile water. And yet, this humble medical staple has become a symbol of everything broken about hospital pricing in the United States. We will start with the 5 main reasons these charges reach the stratosphere, then flip the script and give you 5 real, tested strategies to fight back. From manufacturing monopolies to insurance smoke and mirrors, we are going to expose the entire system with hard numbers and true stories. Let us get into it. Reason number 5, manufacturing monopolies and shortages. You might think a simple bag of salt water, essentially a 0.9% sodium chloride solution in sterile water, should cost next to nothing to produce. And you would be absolutely right. According to reports from the FDA and from manufacturers like Baxter International, which controls roughly 60% of the U.S. market, a 1-liter bag costs just $1 to $2 to produce at the facility level. That is up from about 46 cents back in 2010, but we are still talking pocket change compared to what patients are eventually charged. So why does the price skyrocket? The answer lies in a dangerous combination of concentrated market power and catastrophic fragility. When you have only a handful of companies producing the bulk of the nation's IV fluid supply, any disruption to any one of them sends shockwaves through the entire healthcare system. And disruptions, as we have seen, are not rare. They are cyclical and inevitable. Take Hurricane Maria in 2017. That storm devastated Puerto Rico, which at the time was producing a significant share of the country's IV saline supply. When those manufacturing plants went dark, the entire U.S. hospital system scrambled for alternatives. Prices spiked 5 to 6 times above their normal rates, practically overnight. Hospitals were paying emergency premiums to import bags from overseas suppliers, and those costs did not stay inside the hospital's budget. They were passed directly to patients. And it happened again. Hurricane Helene in 2024 flooded a critical Baxter facility in North Carolina, a plant responsible for supplying approximately 60% of IV fluids nationwide. The American Hospital Association reported that the disruptions caused shortages that rippled across hundreds of hospitals, forcing administrators to ration supplies and pay elevated rates for what remained available. This is not a freak occurrence. This is what happens when you allow a critical medical supply chain to rest on the shoulders of 2 or 3 private companies with no meaningful backup infrastructure. A 2013 investigation by the New York Times laid out exactly how limited the supplier landscape is. Baxter, ICU Medical, and a small number of other players form an oligopoly over a product that every hospital in the country needs every single day. In a truly competitive market, prices might find equilibrium. But in this concentrated environment, any hiccup, a hurricane, a labor dispute, a factory fire, creates scarcity, and scarcity creates leverage. And that leverage gets exercised all the way down the chain until it reaches the patient lying in the hospital bed. The supply side is just the beginning. Once that bag leaves the factory, the hospital system takes over, and that is where the real price gymnastics begin. Moving on to reason number 4, opaque Chargemaster pricing. Have you ever heard the word Chargemaster? If not, let me introduce you to one of the most consequential and least discussed documents in American healthcare. A Chargemaster is essentially a hospital's internal master price list, a document that assigns a dollar figure to every single product, service, procedure, and supply that flows through a hospital's doors. And the prices on it bear almost no relationship to the actual cost of delivering care. A comprehensive analysis by Goodbill, which examined data from more than 2,000 hospitals across the country, found that Chargemaster prices for a standard 1,000 milliliter saline bag ranged from the merely expensive to the genuinely shocking. We are talking about facilities in Florida listing a single bag at $26,667. In Oklahoma, the listed price hit $6,837 for the same product. Now, to be fair, those are outliers. The median price for insured patients hovers around $69, and for uninsured patients, that median rises to $113. But medians do not erase the reality of the high end, and for patients who end up stuck paying closer to the Chargemaster rate, there is nothing median about their experience. What makes this system particularly maddening is that these prices are not anchored to any real cost calculation. They are starting points. They exist to give hospitals room to negotiate with insurance companies, who will demand steep discounts off the listed rate. For insurers with strong bargaining power, those discounts can be enormous. But for patients who are uninsured, underinsured, or caught in an out-of-network situation, the Chargemaster price can become their actual bill, and the result is devastating. Consider what happened during a 2012 food poisoning outbreak in upstate New York. Patients who received identical treatment at the same hospital, saline from the same supplier, administered through the same IV lines, walked away with wildly different bills. One adult was charged $787. A child at the same facility was charged $393. The New York Times, reporting on this case, found markups of 100 to 200 times the manufacturer's price, and that was before administration fees were even factored in. These prices vary by state, too. Oregon tends to show lower median prices for insured patients, while South Carolina consistently shows some of the highest cash prices for uninsured patients. None of these variations reflect differences in the cost of care. They reflect differences in market power, regulatory environment, and the sheer opacity of a system that has never been forced to justify itself to the people paying into it. The Chargemaster is opaque by design. The confusion it generates is not a bug, it is a feature, and it sets the stage for the next layer of cost inflation, the bundling of overhead and administrative fees. Reason number 3, bundled overhead and administrative fees. Here is something critical to understand. When you see that $800 charge for a saline bag on your hospital bill, you are not paying $800 for a liter of salt water. You are paying for a package, a bundle, a comprehensive fee that the hospital has assembled to represent every cost associated with your stay, and then some. Experts and healthcare economists, drawing on data from NPR reports and industry analyses, estimate that the true cost to deliver a liter of saline to a patient's bedside, accounting for pharmacy handling, IV preparation, sterile compliance protocols, staff time, and logistics, lands somewhere between $30 and $50. That is a far cry from $1 to $2 at the factory gate, but it is still a far cry from $800 at the billing department. So where does the rest of it go? It gets absorbed into what hospitals call overhead, facility maintenance, nurse salaries, equipment sterilization, malpractice insurance, administrative staff, regulatory compliance, IT infrastructure, and yes, executive compensation. All of these real costs are bundled into the charges that appear on your bill. The New York Times documented one specific case where a patient's bill showed $546 for 6 liters of saline and an additional $127 for administration. That administration fee for hanging a bag represents a significant markup over the actual labor cost involved. Now, some of this cost shifting is driven by a structural problem that predates any individual hospital's pricing decisions. The American Hospital Association has documented that Medicare and Medicaid payments, which cover a large share of hospital patients, consistently fall short of actual costs. In 2023 alone, Medicare and Medicaid reimbursements covered only about 83 cents of every dollar hospitals spent on those patients, leading to a combined shortfall of approximately $130 billion nationally. To stay solvent, hospitals shift those uncompensated costs onto the patients who are covered by private insurance, and especially onto those who have no insurance at all. This is not unique to saline. It applies to every line item in a hospital bill. But saline is the example that makes it visceral, because the gap between the actual product cost and the final charge is so extreme. When overhead is real but unexplained, when bundling is done without transparency, and when patients have no way to evaluate whether the fees they are paying are reasonable, that is not just a market inefficiency. It is a predatory structure masquerading as standard practice. Reason number 2, insurance negotiation tactics. By now you understand that the Chargemaster price is not the price most people pay. That is somewhat reassuring, until you understand why Chargemaster prices are set as high as they are in the first place. The inflation is not accidental. It is strategic. Hospitals set artificially high Chargemaster prices specifically to create negotiating room with insurance companies. The higher the listed price, the more dramatic the discount an insurer can claim to have won for its members, and the more the hospital can still collect while appearing to offer savings. Here is how the game works in practice. A hospital lists a saline bag at $800 on the Chargemaster. An insurance company like Aetna negotiates a contracted rate, say $240. The insurer presents this as a massive win for its policyholders. The patient pays a copay of $50. The insurer pays the rest, and the hospital collects $240 for a product that cost it $30 to $50 to deliver. Everyone in the system has a reason to perpetuate the inflated starting price, because the inflated starting price is how the entire negotiation theater works. But here is who gets left out of this theater: uninsured patients, underinsured patients, and patients who receive care from out-of-network providers. For these individuals, there is no insurer at the table fighting for a discount. They face something much closer to the Chargemaster price, and that is by design. The advisory board and other healthcare research organizations have noted that this two-tiered pricing system, where insured patients pay dramatically less than uninsured patients, is not a flaw in the system. It is the system's architecture. The specific Aetna case is worth dwelling on. In a documented exchange, an Aetna-insured patient was billed $91 for a Saline bag that cost the hospital approximately 86 cents to acquire. Aetna described this as consistent with industry standards. And in the narrow technical sense, they were right. It is consistent with industry standards. But consistency does not mean acceptability. Insured patients might pay a median of $69. Uninsured patients pay a median of $113. Depending on circumstances, either of those numbers can feel like extortion, when the product itself costs less than $2. If this system makes you angry, good. But anger alone does not pay a bill. The real problem is that this structure has been normalized for so long that most people do not even know they have the right to push back. And the biggest reason they do not know? The final culprit on our list. And now we arrive at the top of our list. Reason number 1: lack of transparency and profit-driven billing. At the core of everything we have discussed today is a single fundamental problem. There is no requirement, at least not one with real teeth, for hospitals to explain to patients why they are charged what they are charged. The Chargemaster has existed for decades as a legally protected secret. The negotiations between hospitals and insurers happen behind closed doors. Patients receive bills that the New York Times has accurately described as hieroglyphics, dense columns of codes, abbreviations, and figures that even medical billing professionals struggle to decipher. A significant policy step came in 2021 with the Hospital Price Transparency Rule, which requires hospitals to post their Chargemaster data online in a machine-readable format. This was supposed to change everything. In theory, patients and employers could now compare prices across hospitals and use that information to make smarter choices. In practice, compliance has been inconsistent. The published data is often formatted in ways that resist easy interpretation, and prices at most hospitals have not meaningfully changed since the 2013 exposés that first brought this issue to national attention. Goodbill's 2022 analysis found that 100 to 1,000 times markups persist across the industry with remarkable consistency. Hospitals have continued to pursue patients in court over unpaid bills, winning judgments and garnishing wages, while simultaneously reporting operating surpluses and paying their executives millions of dollars annually. Nonprofit status, which most American hospitals enjoy, requires those organizations to provide charity care to the community, but the threshold for what constitutes meaningful charity care is loosely defined and inconsistently enforced. The secrecy is structural and self-reinforcing. When patients cannot easily find out what a procedure costs at one hospital versus another, they cannot shop for care the way they shop for any other service. When the codes on a bill are indecipherable, errors and overcharges go undetected. When the negotiated rates between hospitals and insurers are confidential, employers and individuals cannot evaluate whether their insurance contracts are actually delivering value. The entire system benefits from the confusion it generates, except for the patient. That is the machine. Now let us talk about how to fight it. Let us start our countdown of solutions with tactic number 5, request an itemized bill and check for errors. This one sounds simple, and it is, but most people never do it. When you receive a hospital bill, you will typically get a summary, a few broad categories, and a total. Do not accept this. Call the billing department and explicitly request a fully itemized bill that lists every single charge with its corresponding billing code. You are legally entitled to this information. Why does it matter? Because up to 80% of hospital bills contain errors, according to research from Experian and Goodbill. These are not always intentional, but they are always costly. Duplicate charges for the same item. Billing for procedures that were ordered but never performed. Incorrect quantities. And yes, sometimes outright fraud. For Saline specifically, look for billing code J7030. Compare what you were charged against published fair market prices. Goodbill and Healthcare Blue Book both allow you to search fair prices for your area. If you were billed $113 for a bag that benchmarks at $60 to $70, you have grounds for a dispute, and disputes, when filed, often succeed. Tactic number 4, apply for financial assistance or charity care. This is one of the most underutilized resources in the entire healthcare system. Approximately 60% of hospitals in the United States are nonprofit organizations, and because of their nonprofit status, these hospitals are legally required to offer financial assistance programs, often called charity care, to patients who qualify based on income. Income thresholds vary, but many programs extend eligibility to households earning up to 200 to 400% of the federal poverty level. That can translate to as high as $60,000 annually for a family of 4. If you qualify, your bill may be reduced by 50 to 100%. Even if you are not sure you qualify, apply anyway. The application process is free, and the worst possible outcome is a denial, after which you still have other options available to you. Organizations like $4 have made it their mission to help patients navigate these applications at no charge, and they have collectively helped forgive billions of dollars in medical debt for people who had no idea this path was even open to them. If you are dealing with a for-profit hospital, ask whether they have a similar financial hardship program. Many do, especially in competitive markets. Do not assume the answer is no before you ask. A polite, direct request opens doors that silence keeps permanently closed. Tactic number 3, negotiate directly with the hospital. This one makes a lot of people uncomfortable, and that discomfort is understandable. Healthcare feels like a domain where the institution has all the power and the patient has none. But that is not actually the case when it comes to billing. Call the billing department. Ask to speak with a financial counselor or a billing supervisor. And then ask this exact question. What is the settlement amount if I pay today? Many hospitals have discretionary authority to reduce bills by 30% or more for patients who are willing to settle with a lump sum payment. They would rather collect something quickly and cleanly than pursue a long, expensive, and uncertain collections process for the full amount. Cash in hand today is genuinely worth more to their accounting department than a theoretical payment down the road. Use that reality as your leverage. Be polite and persistent. Cite genuine financial hardship if you have it. Reference price comparison data. If nearby hospitals charge significantly less for the same services, say so specifically. According to NPR reporting, patients who go into these conversations prepared and calm have the highest success rates. If a lump sum is not an option, ask about no-interest payment plans. Many hospitals offer extended terms over 12, 24, or 36 months without additional financing charges. The worst they can say is no. And even then, the conversation often opens a door to accommodation you would never find by simply paying the bill as issued. Tactic number 2, research and compare prices before you dispute. Knowledge is leverage. Before you make any call to a billing department, before you file any dispute, spend 30 minutes researching what the services you received actually cost at other facilities in your area and what they cost in other developed countries. The information is more accessible now than it has ever been, and using it changes the nature of every conversation you have about your bill. Tools like GoodBill and Healthcare Bluebook make price comparisons significantly easier than it used to be. State disclosure websites, which have expanded since the 2021 Hospital Price Transparency Rule took effect, offer searchable databases of negotiated hospital charges by procedure and service type. Federal law now requires hospitals to post this data online, and while compliance has been uneven, the information that is available can be genuinely powerful in a negotiation. For Saline specifically, a fair benchmark in most U.S. markets is under $100 total, including administration. In much of Europe and Canada, the same product is administered for under $10. While you cannot walk into a billing dispute with a European price sheet and demand an exact match, international comparisons illustrate how inflated U.S. hospital pricing has become relative to any rational baseline. When you walk into a billing conversation knowing what is reasonable and being able to articulate exactly why the charge you received falls outside that range, you are in a fundamentally stronger negotiating position than someone asking for help with no data to support them. And the most powerful strategy on our entire list, tactic number 1, hire a medical bill advocate. For large bills, complex insurance situations, or any case where your own efforts have stalled, the smartest move you can make is to bring in a professional. Medical bill advocates are specialists who understand hospital billing codes, insurance contracts, appeals processes, and the specific pressure points that move billing departments. They know where errors hide, which arguments work with which types of billing offices, and when to escalate to a formal insurance appeal versus when to negotiate directly for a reduced settlement. And critically, they do this every day, bringing institutional knowledge and relationships that individual patients cannot replicate. The economics of hiring an advocate make sense for significant bills. Organizations like $4 offer completely free assistance for patients pursuing charity care applications. They handle the paperwork, follow-up, and appeals at no cost to you. Services like GoodBill work on contingency, They charge between 20 and 35% of the savings they generate, which means if they cannot reduce your bill, you pay nothing. Advocates have turned $15,000 bills into $150 final payments. They have recovered thousands in erroneously charged fees that patients had resigned themselves to paying. For an $800 saline charge that has become part of a larger hospitalization bill reaching tens of thousands, the right advocate is not just helpful, it is transformative. Let us take a step back and pull this all together, because every piece of what we have covered today connects to every other piece. The story of the $5 saline bag that costs $800 is not a story about one product, one hospital, or one bad actor. It is a story about a system, an interlocking web of incentives, structures, and deliberate opacity built over decades and never meaningfully reformed. Manufacturing is concentrated in the hands of a small number of private companies, making the supply chain brittle and expensive when anything goes wrong. Chargemaster prices are set not to reflect the actual cost of care, but to create a negotiating buffer that most patients never personally benefit from. Overhead and administrative fees are bundled without transparency into charges that obscure what any individual item actually costs to provide. Insurance negotiations create a two-tiered pricing reality that punishes the uninsured and underinsured, often the patients who can least afford it. And the entire structure is sustained by a deliberate absence of price transparency that keeps patients in the dark about what they are paying, what they should be paying, and what their rights actually are. These markups are not accidents. They are not inefficiencies waiting to be corrected by a well-designed app or a new federal regulation. They are features of a system deliberately optimized for revenue generation, and dismantling them will require sustained, coordinated pressure from patients, employers, policymakers, and the public over a long period of time. But while we wait for systemic change, and we should keep pushing for it, you are not powerless right now, today, with that bill sitting on your kitchen table. Request the itemized bill and read every line. Check every charge against fair price benchmarks. Apply for charity care before assuming you do not qualify. Pick up the phone and negotiate directly, armed with data and a clear number in mind. Research prices before any dispute conversation. And if the bill is large enough or the situation complex enough, bring in a professional advocate who fights this battle every single day with expertise and leverage individual patients cannot replicate. Every one of these tactics has worked for real patients in situations that felt impossible. The system counts on your confusion, your exhaustion, and your silence. It counts on you assuming the bill is fixed, the number final, and the institution infallible. Do not give it any of those things. Share this video with someone who just got a hospital bill they cannot make sense of. Leave a comment if you caught an error on your own bill, successfully negotiated a charge down, or used charity care to reduce what you owed. The more we talk about this openly, the harder it becomes to sustain a system built on secrecy.